Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated.
I'd like to welcome all of you to the November edition of Family Medicine Grand Rounds. And very exciting round today as we are going to hear from our Pembroke group. And it's my pleasure to introduce our first speaker and facilitator of today's rounds, Dr. Richard Johnson. Richard's a family doctor in Pembroke, as well as the site director of the Pembroke Residence Program, and he's chief of family practice at the Pembroke Regional Hospital, chair of the Renfrew County and South Algonquin Primary Care Community of Practice. He is 6 years into practice, having graduated from the Pembroke Residency Program. His passion is maximizing the health of residents in this region, and he's supported by his wife and lovely kids, two kids, who attempt to keep him balanced. So, Richard, without further ado, I hand the reins over to you.
Thank you for the intro, Doug. So I'm privileged to be moderating this session today and bringing to you three of our local healthcare leaders from Renfrew County. Over the next hour, you will hear from Dr. Jonathan Fitzsimon about his team's innovative project to solve one of our key local issues, which is access to primary care. You will also hear leadership lessons from Dr. Declan Rowan, so that you feel empowered to take on healthcare challenges that you are passionate about. And if all this was too high in the sky and you just want to find out how to start your own comprehensive family practice, then start paying attention when Dr. Lynsay Lane is talking about the alphabet soup of primary care practice models. So to start off, I will just give a quick overview on some stats for Renfrew County to kind of set the stage and then hand it over to our three speakers. I myself have no conflicts to declare. Renfrew County, we have 5 main hospitals spread over the large region, Arnprior, Renfrew, in Pembroke, Deep River, and Barry's Bay. And they all are of various sizes. Our population is very spread out across this region and does center along those main larger towns. The population of Renfrew County is approximately 107,000 people. The average age is 44, which is 4 years above the Ontario average. We have 2% visible minority, which is quite a bit lower than the Ontario average of 26%, and only 5% immigrants versus the Ontario average of 28.5%. 7.6% of our population self-identifies as Aboriginal. Overall, across the county, we have lower income levels and lower education levels, but this does vary dramatically by community. Our smoking rates are quite a bit higher, at-risk drinking rates are higher, and obesity rates are higher than the Ontario averages. So without further ado, I'll bring you to our first presenter. Dr. Jonathan Fitzsimon is Chief of Medicine at the Arnprior Regional Health and Clinical Coordinator of Renfrew County Virtual Treatment and Assessment Center. There are high levels of unattached patients across the county and a high burden of disease. It's March 2020 and COVID has come. What's our plan?
Hello, I'm Jonathan Fitzsimon. First and foremost, I'm a family doctor. I'm also Chief of Medicine at Arnprior Regional Health, and since March this year, I've been the Clinical Coordinator of the Renfrew County Virtual Triage and Assessment Centre, or VTAC. Today, I'd like to share with you and talk to you about the evolution of virtual care and how we have started using virtual means to deliver primary care and improve access to family physicians. Now, Arnprior is part of Renfrew County, which is the largest geographic county in Ontario. We have a population of around 107,000 people, but they're spread over 7,500 square kilometres. 5 of the towns in the county, including Arnprior, where I'm based, have a regional hospital. But there are many more smaller and more rural communities spread across the 7,500 square kilometres. Lots of the population live in quite remote settings, including the First Nation community of Pikwik-Onagon. And many of the communities are underserviced when it comes to access to primary care. So 25% of the population do not have a family physician. There are no walk-in centres in Renfrew County. There are no urgent care clinics. So for thousands of people, their only access to any form of healthcare is through the emergency department. And then along came COVID and the call for COVID assessment centres. Well, there was no way that a fixed site assessment centre could service our population, and there simply weren't the resources to set up multiple assessment centres, even in the larger towns, let alone the smaller and more remote communities. So we developed a virtual triage and assessment centre. Now, under the surface, it's a pretty intricate organisation. There was incredible collaboration and cooperation between primary care, the County of Renfrew Paramedic Service, the hospitals, public health, and many other community healthcare providers. However, from the patient perspective, it's beautifully simple. You call a single free phone number and you speak to a medical receptionist. When a patient speaks to the medical receptionist, if they met the criteria for, or if they meet the criteria for a COVID test, they can book in a time slot to one of the drive-through sites that the community paramedics run. For vulnerable housebound patients, a paramedic can go to a patient's home. If they need to speak to a family doctor and they don't have a family doctor, or they can't access their family doctor, then they're given a same-day telephone appointment with a VTAC physician, and that can be upgraded to a video appointment. Now, when we set it up, one of our key objectives was to protect our emergency departments and 911 paramedics, and make sure that at the same time, nobody was left at home to suffer in silence. So if a patient has symptoms of COVID, they can be assessed by a doctor, and they can have a COVID test if they need one, which will be done by a paramedic at the drive-through site. Now, if the family physician, as part of the assessment, wants additional assistance and information, they can request for the paramedic to go to the patient's home, and the paramedics can do physical assessment, vital signs, point of care testing, and if needed, leave behind equipment for remote monitoring. Now, if somebody has a health concern that isn't obviously COVID related, then a huge problem for us in Renfrew County is that the normal action is for people to go to the emergency department. And yet we didn't want people going to the emergency department in large numbers, sitting in waiting rooms and congregating there, because that would be a COVID risk and a COVID issue, regardless of their actual presentation. So 46% of people that have a phone appointment with VTAC say that if it hadn't been for VTAC, they would have attended the emergency department. And yet only 3% of our calls end up with a transfer to the ED or to 911. But what we also found is 30% of people would have done nothing. They say they would have stayed at home and not sought help for their health concern. So we're protecting our emergency departments and we're preventing people from suffering at home in silence. We can link patients to all of the other existing resources that we have in the community, from mental health services through to palliative care, services that many people don't usually access because they don't have a family physician. To date, we've completed over 14,000 family physician appointments. We've had over 4,000 paramedic home visits and over 26,000 COVID tests. And the truth is that VTAC has been a lifeline to the people of Renfrew County. We've shown how flexible family physicians can be, how nimble we can be to change in order to support our communities, and also how well placed we are to be at the center of new innovations, new services, especially those that require cooperation and collaboration with other healthcare providers. I think for me personally, despite the very long hours, it's been an incredible experience. Wonderful to be part of a talented and dedicated team. But the story doesn't end with VTAC. Firstly, VTAC is a response to the COVID pandemic. It's an official COVID assessment center. And we got to realize that at some point, assessment centers will evolve, be modified, and likely close. But the desperate need for better access to care in our communities will continue. The second point is that, look, I'm number one in line to point out that VTAC does not provide primary care. It's an excellent vehicle for providing acute episodic care, especially to patients that don't have a family physician. But it's not a good vehicle for providing health promotion and disease prevention. It's not a good vehicle for chronic disease management. And if we truly want to use virtual care as a means of, increasing genuine full spectrum primary care, then we need more than VTAC. So the Virtual Family Health Team, or VFIT, is a pilot project currently underway at the Petawawa Centennial Family Health Centre. And this evolution of VTAC aims to build on the positive lessons that we've learned about delivering healthcare virtually with VTAC. However, the Virtual Family Health Team, VFIT, is designed to take the extra steps that are required to ensure that patients can receive the full spectrum of primary care. I think at this point, it's important to point out how successful and acceptable to patients that virtual care is. 86% of VTAC users say that their concerns were dealt with at the initial appointment. 93% say they're happy or very happy with the service, and 98% would recommend it to family and friends. And, I challenge anyone to get those sort of satisfaction scores in primary care. I know me and my colleagues in my office don't come close to those. But these satisfaction scores for VTAC correspond to the CMA Abacus study, which came out in May this year, and that looked at the response of all Canadians to virtual healthcare. So VFIT enables patients to roster to a family physician, to a named family physician. It's collaborative, it's multidisciplinary, it's a primary care team. We provide a combination of virtual, in-clinic and at-home care. So the physician works remotely and the patient speaks to their doctor by phone, or they see them by video link, and eventually we'll be able to connect patients with the doctor via secure messaging. Local allied health professionals based in the Family Health Centre provide options for in-person care. Community paramedics provide options for home visits to vulnerable housebound patients. We have arrangements with local surgeons to provide options for procedures and local sports medicine physicians to provide joint injections. We've got new technology such as Bluetooth stethoscopes, examination cameras, and that enables patients to attend the clinic, and with the support from an allied health professional on site, they can receive their care from the family physician via video link, so sort of telemedicine techniques for primary care. And this means that the patient's named family doctor is at the heart of the primary care team. They can help the patient navigate the healthcare system. They can provide access to existing services and become that sort of trusted first point of contact for healthcare. And when you compare this to the current situation of thousands of people in our community, of the emergency department being the only option for any form of healthcare, then VFit is a giant leap forward. And I think it also offers the potential to be part of the solution to address this problem of the terrible inequality of access to primary care in rural, remote and underserviced communities. There is no single one-size-fits-all solution to the challenges of delivering better access to primary care. But I think virtual care can be part of the solution. And there really is a tremendous synergy between family physicians, community paramedics, and a multidisciplinary primary care team, especially with virtual care technologies and techniques added in. So in the words of Dr. Ewan Affleck, who's the co-chair of the virtual task force, and he spoke pre-pandemic in February this year, and said, we have to change who we are as medical professionals to work in a digital environment because we largely are practicing analog healthcare in a digital world. I appreciate the opportunity to share the story of VTAC and VFit. My apologies, there seem to be some technological issues there with the pre-recorded version. I hope over the coming months and years, we'll be able to share many more success stories about the benefits and utility of virtual care and how it can be used as a way to improve access to family physicians and primary care. Thank you.
How do we spread that across Ontario and actually even spread it further? So that I could see this model, although you had, your 20% unattached patients in your rural area, and then the geographic distribution, it certainly would be applicable in an urban environment as well. So any thoughts on what some strategies could be to spread this? Could we implement this in Ottawa?
Yeah, it's a great question, Claire, and it's obviously something we've been talking a lot about. And I think, the first step is to spread the word as to what we've been able to do and what we've been able to achieve. The next step is to demonstrate, certainly to the Ministry of Health, what we are achieving with VFit. And I think there is a little bit of a mindset change from not letting perfection to stand in the way of really good progress. And so some people still have this hesitation that seeing your doctor virtually is not as good or is not the same as being able to walk into your clinic. And for some people that might not work, but I think when we show just how many thousands of people are really truly benefiting from this, both in their personal progress and their ability to access healthcare, but if you want to be hard-nosed about it, the financial implications of giving people better access to healthcare and preventing them turning up at emergency with more complicated disease, I think that first step of demonstrating our success is going to be key. Because, the wider point to your question is this: can this work in urban areas as well as more rural areas? Absolutely. It's not just rural and remote communities that struggle with good access to primary care. There are certainly huge disparities in urban areas between the models of primary care as well. Standalone fee-for-service physicians compared to well-funded, well-staffed community health centres. That's an issue in big cities as much as it is in the rural communities. So I think showing people what we can do, demonstrating our success, and we've got a number of strategies for doing that, is going to be the first step to pushing this out wider across the province and across Canada.
Excellent. So thank you, Jonathan. So we have time for one more question. So Sharon has posted in the chat. So on the fee structure. So currently the fee model is based on the Virtual Treatment Assessment Center funding, which is a stable hourly rate. How do you think we sustain this long-term, Jonathan?
Yeah, another great question. Thanks, Sharon. So the VTAC model, like you say, is funded as under the assessment centre funding model with sessional fee codes. There's strong advocacy going on at both at clinical and municipal political level to maintain this in some way. And there's lots of sort of discussion and negotiation going on to see if there's a way of continuing sessional fee codes to this form of triage and assessment centre, even when it loses its COVID assessment centre designation, which I'm sure will happen at some point. In terms of the virtual family health team, again, we're advocating and pushing hard to not be tied into a fee-for-service model, trying to recruit a physician to this new innovative model of care and then saying, oh yeah, it's just fee-for-service and you build a virtual fee code. It just loses its shine instantly. So we're trying to work with the ministry to find a way where the Family Health Centre, for example, has gapped posts. So they have funding, budgeted money to pay for new physicians. They just can't recruit them. And these are salaried physician posts, but they can't get the physician to relocate to the rural communities. And so what we want and what we're advocating for is permission to use those funded salaried posts to pay physicians as salaried physicians, but on the understanding that they're going to be working remotely, supported by the on-site multidisciplinary team. So that's our hope, and I'm happy to share with you our progress on that over the coming weeks and months.
Thank you, Jonathan. So if you have any more questions for Jonathan, feel free to post them in the chat. So next up is Dr. Declan Rowan. He's a family doc at the Petawawa Centennial Family Health Team. He's Chief of Hospitalist Medicine at the Pembroke Regional Hospital and a leadership teacher extraordinaire. He's an informal mentor of mine and no doubt countless of other physicians.
You're very kind, Richard.
You're up live on no notice.
I'm live. Okay, thanks everybody, and delighted to be here chatting with you. So Richard asked me to speak a bit about physicianship for early leaders. So we'll see how this goes today. Hopefully I won't be as jumpy as the video. So I have nothing to declare in terms of conflicts of interest. I think what I just want to kind of mostly focus on, though, and often when we think about leaders, we think about the big L leadership, and people in leadership posts. But I really want to reiterate to all of us, and including you residents, that you are a leader, and I think not having a formal leadership title isn't really important. Just being a physician itself means that you will be seen as a leader, both where you work and especially in the community where you are working and often living too. So what I'm trying to concentrate on is, kind of what are some of the skills and approaches you might take in your early career to kind of help lead, and often it'll be leading some changes, perhaps where you're working or other skills. I promise Liz Mugger didn't pay me to put this slide up, but I do want to reiterate that quality improvement is an important skill for us to at least have some knowledge and ability to look at. It's an important skill for leading change. You won't know if your change is successful if you can't really measure it. But I'm going to not talk about, you'll be pleased to hear, I'm not going to talk about quality improvement because really, while it is important, I believe that it's really insufficient and it's not enough. And the reason for that is that even what we might think is the most simple kind of change that we're going to do within our practice or within our office will be really straightforward. Actually, in many cases, turns out to be incredibly difficult to do and sometimes incredibly frustrating. And I want to kind of highlight some approaches that might help ease some of the frustration as you kind of get going in your work and as you're kind of working and noticing processes or other things that need to change where you're working. I'd encourage people, if you are interested, to have a look at this article. It's from way back in 2001 in the BMJ on the challenge of complexity in healthcare. It was a great little article just explaining, how complexity and how difficult change can be in an ordinary family doc or GP's life. And they gave a case study about a GP who was working in an office who found there was issues with people who were working and had difficulty attending the office and wanted to kind of change how the appointment times were timed to try and accommodate more people to get into the office. And it turned out what she thought would be a very straightforward process into really, really difficult. She'd set out some information, gave her idea, planned a meeting. The meeting went on forever. Many of our colleagues totally opposed it, boycotted the meeting. And she was left feeling very frustrated and said, you know, this works everywhere else. You know, my brother practice, it works. You know, what's all the fuss here? And sometimes when we're trying to make changes that we think are very simple and we're stymied, it can be incredibly frustrating and have a big impact where we're working, incredibly big impact, in fact. And I think, you know, this is a great, I love this picture because often we think about changes as, and even things that we think might be simple, but actually, you know, when we get down to it, the answer in trying to make changes where we're working or anywhere can actually be really, really difficult and complex. So the lesson to learn is, I think, that to expect that change isn't going to be as simple as we think, and it is going to take a fair bit of exploration. And I'm going to give you a couple of approaches that you might kind of take to try and drive some of this along and make it a bit more smooth sailing for everybody. And this, I think, is one of the key skills that we're all guilty of. And I'm going to hold my hand up and say I'm totally guilty of this from time to time. Often when we think about, so, you know, something going on in our office that needs to be changed, a process, or there's a problem, and we come up with a great change idea. We think this is the thing that's going to change everything and make everything better. So we present it as, you know, we could do this or this, you know, or we go, I think we should do this. So on the left-hand side, we come up with the issue and we decide ourselves what the desired outcome might be. There might be one or two, and we give people a choice. We could do this or this. What do you think? And that's where we intervene. And that's actually the most common thing to do. And surprisingly, many, many people say, hold on a second, that's not all the way that we can do this. There'll be a whole degree of resistance for all hosts of reasons. And some will be told to what they are, and many won't be, but there'll be all kinds of resistance to it. And really what the idea of it is to kind of dial it back up and actually start talking about the issue. Start talking about what you think the desired outcome might be with people, but actually get people to think a bit about, is this an important issue for other people where you're working? Are there other aspects to it? Can people come up with what's called a shared outcome to kind of see where we can work on it? Can people then decide together on a degree of options and make a choice together? So that's the difference between you're asking people to buy into your choice of what people should do, rather than people to become investors or to take ownership of these choices that they develop. And if there's one key lesson to learn, I would say that this is it. You know, people will support what they help create. If you're working somewhere and you're not allowing people to help create the change or whatever's going on, chances are that you're going to get support will be a lot less. I love this slide too. I got this from a leadership course that I did. So it really is about kind of looking at how you focus on the issues at hand. Many times we focus on the problem. Hopefully, although it does happen at meetings and where we're working, there can be a fair bit of drama sometimes, but often we focus on the problem, or sometimes even the details around the problem. Often we spend a lot of time then planning around it, but all of that is kind of, again, insufficient. The first step I would encourage everybody to do is take it back up to a vision. So if you think about this GP in England who was trying to change the appointment times, if there was a discussion first, I think, about a vision of trying to improve access, and access kind of broadly, and looking and exploring that in more detail, and having a vision of we're going to provide the best access or as good as access as possible, and allow then people to take investment in planning and understanding what the problems are. I think there would be a much better approach. She presented it with a couple of change ideas way down and asked people to buy into her idea. And this is why it's so important that if you can get a compelling vision that everybody agrees on, all those other gray areas where people are kind of scurrying around thinking about their individual problems, you can start to think about, you know, does the work that we're doing, is this change idea actually aligning with kind of what we're looking at? Is it look at how we're trying to move this? Does that really improve access for the patients coming to our clinic or not? And then once you have that vision, that's really where the quality improvement process kind of kicks in. And I like to kind of think about change processes as being a bit of it's a bit like sailing. It's not a straight line. You're not going to go from where you're at to where you hope to go in a total straight line. And the whole idea of the quality improvement is to measure where you're doing along the way. And if things aren't going as well as you thought, The idea then is change your bearings, change your sail, tack back a bit, and readjust where you're going, and off you go again. And eventually you kind of get around to where you hope to go. And the interesting thing about it is that when you start this journey, which is more complexity, where you thought you were going to start, you could end up at the beginning of this often ends up to be slightly different or even completely different. And that's okay too. I'm going to give you a very quick story about us here. So it's back when we were giving out FOBT kits, but in Ottawa, we were trying to increase colorectal cancer screening. And the idea was to have the kits given out by the reception. And so there wasn't a lot of engagement. I guess the choice we gave them was you could give it to people as they come in for their appointment or as they leave for their appointment, from their appointment. But that's about it. And of course, you know, going back to that original slide about engagement, it was clearly this was going to fail. And this staff gave all kinds of reasons regarding the workload and everything about it, that, you know, why they couldn't give out these kits. So we took a step back and looked at it again. And I came across this great video from Kaiser Permanente, and it was about a patient who came back to thank the staff for saving his life, for giving a fecal occult blood test kit for doing his colorectal cancer screening. It was a very emotional kind of video, and this is a screenshot of him hugging the staff member who gave him the kit, and it was a great video. But it really changed the conversation with our front staff who were in for this meeting, and it really changed it from them doing tasks for us, the doctor, or to them being a core member of the team and a vision of them, you know, saving lives, if you like, improving screening. And it really changed the way that they thought about it, and the uptake of them working to try and improve how they gave out the kits. It really improved. The other skill that I want to just very quickly talk a bit about is how you handle meetings a bit and how you handle interactions with people. I don't know how many meetings you attend as residents, but many people who attend meetings will probably describe them in terms of what might be in this elephant on the left. You know, people feel disengaged, bored, excluded. There's all kinds of negative connotations about meetings. So there's a way of kind of trying to structure the meetings or structure engagement between meetings to try and improve things and make them look a bit more like on the right. Obviously, this was pre-COVID times. So liberating structures is a great little tool that's easy to learn to allow engagement for people. It can be done informally, but it's a great way to try and get people talking and engaging more together, and I encourage you to have a look at it. There's a whole host of different ways of structuring the meeting. I'm not going to go through every single one of them. There's a great website, liberatingstructures.com, book, and there's even an app for it. But you can actually try these and learn them yourselves. They're very, like I said, they're very, very straightforward. And you can actually do them over Zoom as well. And Richard and I have done a few of them as well. They've been really, really quite helpful. The easiest one of all to do is this one called 1, 2, 4, all. And the reason why it's so important is that in many times in meetings, people who have something to say often don't say it at all within meetings. And the things that that people want to say, it just never kind of comes out. And meetings are held with a rigid agenda, and there's not a lot of time for really good, deep discussion. And the way that this occurs is that you pose a challenge. You know, how are we going to improve access in our clinic? How are we going to improve our colorectal cancer screening rates in this clinic? So we ask about people to reflect on how they might have opportunities and reflect on it themselves for about 1 minute, and then turn to their partner beside them in pairs. So you can go into breakout rooms on Zoom for this and spend a couple of minutes. I would suggest if you're doing it on Zoom, you need a bit longer than 2 minutes, but have a couple of minutes to reflect on the ideas that came up from self-reflection in pairs. And then you bring it back to a group of 4 and you discuss it even more together. And what you'd start to see is that there's some similarities and differences in the ideas that kind of pop up. And then you bring it back to the room again. And it's a really great way of engaging everybody within the discussion. And it gets people who are knowledgeable, it gets people who are at the front line involved with some of this change to come up with some solutions. And people become much more motivated and committed to the change themselves. Remember, people feel much more engaged and will help support things that they feel are involved with the change. And the other thing about it is, which is really important, is it starts to build this human-to-human relationship. Like meetings are not a great way for building relationships, but this kind of interaction really helps get people talking together. People get to understand other people and that they're working along with. And it really, that part of relationship is really important. People often say that change happens at the speed of trust. And that is really true. And the more you get to know the people you're working with and discuss things with them, the more likely you are to have it. And by and large, meetings who have used some of these liberating structures, people say that they're definitely much more productive. So I would ask, I love this slide as well, your comfort zone, the magic happens when you step out of your comfort zone. So if you are leading a bit of a change process, even with some of your colleagues, have a look at some of these liberating structures, try them, step out of your comfort zone and give it a go. They can be great fun, and it's a safe space for you to try them in with your colleagues and with others, and it's well worthwhile giving it a go. Finally, I'm just going to talk a little bit about some training strategies that you might want to think a bit about. So you may be aware that Jewel has a lot of physician leadership courses. It's a CMA company. Many of them are listed here, and there's others as well. They are, I believe there's a resident rate for them. And if you are thinking about more formal leadership courses, it certainly would encourage you to look at those. The other course that I think is a great one to look at is a free one from the NHS. It's called the School for Change Agents, and it's really about how to drive change within your organization. It's about 6 or 8 weeks. It's done online. You can look at previous years to see what they look like. They're all on YouTube, and the slides are all on SlideShare. It's a great little course. I've done it myself, and it does teach you some great skills about how to drive change and to lead change. The first one often is Change Starts With Me, but there's a whole host of different courses within it, and it's well worth having a look at if you've time. They take about an hour and a half, and they're very light, and there's people all over the world that are doing them, so it can be quite enjoyable. Lastly, I just want to again go back to just say that, when you are looking to drive change where you're working, even if it seems very simple, it can be incredibly frustrating because of the complexity and because we're all humans. So I would encourage you to pay as much attention to the social side of change, talking to people and understanding why people do what they do and understand them, rather than getting people to do what we want them to do, and to be supportive and to provide a supportive pattern and supportive structures for change. And lastly, to try understand a little bit about the dynamics of us complex human beings who are involved in change. And by taking some of these approaches, I think you'll find any change process you're getting involved with and leading a little less frustrating and much more successful. I am happy to talk to anybody. That's my email. I'm on Twitter too. Delighted to, if anybody's on Twitter, to reach out and follow along together. And there is a good, every week, there's a healthcare leadership educational tweet chat worldwide, hashtag HCLDR on a Tuesday night at 8:30.
I don't have a question, but I do have a comment. I think you delivered in, 10, 15 minutes, what it takes a lifetime for most of us to learn. So I really want to encourage people to keep listening to the clues you gave, the suggestions, the links, because for me, it really resonated. All the elements that you addressed are really part of what makes something successful or not. I sent you a slide on your email. I love that you have, different cartoons. You might find the one I sent you useful for another presentation, because they really deliver the message nicely.
Great, thank you. I look forward to looking at that. I steal slides wherever I get them, so it's great.
That's excellent. Okay, so if you have any more questions for Declan, you can post them in the chat. We'll move on to our next speaker. So we're going to try the pre-recorded one from Dr. Lane. So Dr. Lynsay Lane is a family doc in our clinic, the Pembroke Family Medicine Teaching Unit. She's the medical director of the Miramichi Lodge, which is a long-term care home here in Pembroke. She has a huge interest in the business side of medicine. So pre-recorded Lynsay, bring this back down to earth a little bit. There's a lot of practice models. Why would I choose one over another?
Hi there. My name is Dr. Lynsay Lane. I'm one of the family docs at the Pembroke Family Medicine Teaching Unit in Pembroke. I'm also the medical director at Miramichi Lodge, which is one of our long-term care facilities. I'm going to be talking to you today about practice models in primary care in Ontario. Firstly, disclosures. Aside from supporting and advocating family medicine practice in rural setting as the best place to practice family medicine in Ontario, I have nothing else to disclose. I've practiced family medicine under both the blended salary model in the past and currently practice within a family health organization, which is not affiliated with an FHT. So, quick to start, what is a family health team? So, family health team is a primary care organization that includes allied health providers that are funded by the Ministry of Ontario. They were created in 2005 to try to expand access to comprehensive primary care to Ontarians, and often includes services geared to the certain population they serve, such as Aboriginal health or addictions or anything along those lines. So family health teams have numerous different types of compensation models under their umbrella. So this is your FOs, your FINs, blended salary models, for example. So this is often where the confusion lies. We have lots of different students and residents who visit our office, and we find that it's a consistent problem that the understanding of the practice models versus the compensation models, there's a bit of a knowledge gap there. So I'm hoping we can address that here today. So back to family health teams. This is an umbrella term to identify a practice that receives additional funding by the Ministry for allied health services and administration of those services. So this is not a compensation model as such. So this is a list of our compensation models currently available in Ontario. As you can see, it's a little bit muddy. So what I'll try to do is go through each and try to explain them to the best of my ability. So the first is fee for service, which most people are familiar with. The classic model of, provide a service, bill for the service, and then get paid for the service. It's not an ideal compensation model in primary care. Typically requires a lot of fast appointments, many appointments. Otherwise, there's no payment associated with it. This is not the type of medicine that we're being trained to provide at this stage. So it's important to understand the different services or the different options available. Second is enhanced fee for service. So this includes your comprehensive care model and your family health groups. In this model, the majority of income is still through fee for service billing, but there's also additional incentives and bonuses tied to capitation care for your patients and chronic disease management, preventative care, those types of things. So it's an incentive to provide quality care in addition to quantity of care. Third is the blended capitation model. So this is probably two of the most common models. This includes your family health network and your family health organization, or FINs and FOs. Majority of income through this model is through capitation-based fees. So pennies per day for each of your patients based on their age and gender. There's also some incentive to continue to bill and get paid for certain services that are considered outside the basket, meaning that those are services that you still get paid 100% of the fee code for. These are also tied with bonuses. So pennies and premiums to optimize patient care. There's a good mix of capitation and fee for service incentive in this model. There's also some incentive to continue to provide care that's outside of the umbrella of typical family practice, including prenatal care, obstetrical care, home visits, palliative care, long-term care, which I think brings a lot of value to the experience a doctor can have as a family practitioner. Fourth is the blended salary model. So this is the start of transition into more of a salaried approach to compensation. The majority of this income comes from salary, and it's based on a tiered system of how many patients are rostered to a certain physician. As an employee, there are some benefits. There's no need to worry about a broken fax machine, a reception staff member calling in sick or handing in their resignation. There's no worry about computer issues because that's all managed by the executive director of typically the family health team. It's quite a great model to consider, particularly first out of residency. Fifth is a salaried model. So this is purely from salary. This is often known as community health center. Along with this, there are benefits to a salary and pension. And again, one salary is based on the number of hours they provide at the clinic. Sixth is a remuneration model I'm not as familiar with. It's referred to as the Rural Northern Physician Group Agreement, and it's a compensation model that is majorly made up of income through base rate payments. And this include incentives like locum coverage and overhead payments to try to incentivize the care that's needed in remote kind of rural or northern communities. So I tried to summarize, all of this information the best that I could. So up top, you'll see in blue are the practice models in the blue bubbles. And then below those in the white bubbles are the different compensation models associated with each one. So try to summarize this as a reference tool going forward when you're trying to understand this better, hopefully when you're making further career decisions. So then just to summarize, the FO, the FIN, the blended salary model, all under the umbrella of a family health team, versus your salary model, your community health center, independent practice, and all the different compensation models that are associated with that. Walk-in clinic is generally fee for service. And then the Rural Northern Physician Group Agreement. So I thought this slide kind of nicely summarized the confusion of the information provided. So there's both too much information and not enough information. So we spent countless hours preparing ourselves to practice medicine independently. Personally, I believe that we devote too few hours to understanding the way we're compensated. Make sure you take the time that you have to understand how you are paid. Otherwise, how can you ever hope to maximize your income? But more importantly, how can you avoid burnout if you can't, understand where the dollars are coming from and where your time is most needed to make that? It's taken me over 10 years to gain comfort and get an idea of how things are organized. And like anything in government, that's soon all about to change. So with that, we bring in Ontario health teams. So this is a new term used with the hopes of reconfiguring the delivery of primary care in Ontario. These are currently under development. Many people are asking why do we need to make these changes? And I thought there's a good study in 2015 which highlighted this well. So the study was done to evaluate whether the predicted or expected outcomes of the new comprehensive care models that were created in 2005, whether those benefits were gained or not. So essentially they compared the classic fee-for-service versus the new models. With that study, they did notice an improvement in chronic disease management as well as preventative care rates. There was no notice improvement in hospital admissions or readmissions for that matter, and there was no decrease in emergency department visits, which is quite interesting. So again, back to the drawing board and see if we can make some improvements here. I also think it's important to recognize the other pitfalls of our current models. Certainly they're not equitable. So it doesn't make sense that, two neighbors can have access to dietitian, pharmacy, all these different services free at their family doctor's office, whereas the other one, not being part of a family health team, doesn't have that access. It just, practically doesn't make any sense. And lastly, whether or not this current situation is financially sustainable. So comprehensive primary care is superior, I think, to the historic rapid fire fee-for-service, as it's less rush, often team-based, and more patient-centered. But unfortunately, there's no disincentive to over-enrolling one's practice, to not providing sufficient office hours to care for a roster of patients, and keeping wait times for appointments for patients beyond weeks or even months in some cases. So finding some kind of balance where we can put patients first and optimize this delivery would be excellent. So hopefully with the ongoing effort by all the stakeholders, patients and physicians and government and everyone, we can continue to optimize the access and delivery of primary care in Ontario. Thank you very much.
Thanks. This is great. In fact, I'm gonna, if I can borrow your slides, and I'd love for my team to get really familiar with this. Just if you wanted to say a couple of words in terms of how these models might or might not, there might be a difference or not in terms of how they can support better quality of care. So do you think that there's a difference in the potential quality of care in these models?
Well, certainly I think that there's the opportunity for differences. That's what I was kind of touching on. I think that study highlights well that although we expected a big difference in the fee-for-service versus the more capitation-based, there were no differences in, emergency department visits and these things that I think we all would have expected. So I think, it highlights that good quality care can be provided in any kind of model. But I think the equity piece is really very important to make sure that we have more of a standardized approach to delivery of care, and also supporting family doctors. I think burnout is high, and having the services that you need, be it social workers or dietitians, to help provide the best quality of care would be a solid approach to primary care delivery.
Thanks.
Phenomenal. Thank you for that. So I want to thank Declan, Jonathan, and Lynsay for these phenomenal talks today, and the department for hosting this and the vision to make this larger. It was exciting to be able to speak to you all today. I'm going to hand it over back to Maddie, who's going to tell us about the next talk.
Hi, thank you for everyone for attending, and I apologize for the IT issues, but as we move forward, we're going to work through these. So I just wanted to bring your attention to our next Family Medicine Grand Rounds, which is in January. So I hope most of you can attend. So we have a visiting scholar, Dr. Yoram Singer, and as well as Dr. Parisa Rezafar with her residents, Dr. Yara Abu Amdi and Dr. Farah Naz, who are going to be presenting.